Hello, everyone, and thank you for attending the fourth edition of our Hearing Roundtable 2023 program. This is the Winter Hearing Roundtable this year, and with this we complete the quarterly program of virtual roundtables. Before starting with the roundtable, just let me give you some information about the hearing group, as well as some few housekeeping details. The hearing group was created more than 15 years ago with the intention to gather expert implant centers from all over the world to improve outcomes of hearing implant devices and promote hearing rehabilitation all over the world. Since then, we have been meeting once a year in person, except during the pandemic, of course, to share the experience we have and to share the information and try to improve the world of hearing devices. This is actually the picture of one of our last annual meetings. We are currently 36 hearing implant centers distributed all over the world. And I would like to emphasize that we are centers, not individuals, meaning that each one of these dots here in the map represent teams, including experts in rehabilitation, speech language, programming, imaging, surgeons, and many other specialties. So this is important to understand how the spirit of the hearing is working. Okay, we're, as you all know, we are dedicated to all kinds of hearing implants. And we try to set the standards of implantable hearing devices since 2008. So it's more than 15 years now. So it's been quite a long time dealing with the hearing rehabilitation world. We have an important mission, which is to be innovative, which is to be educational, which is to be coactive and comprehensive. And the idea of being innovative is to stay at the cutting edge of the hearing implant world. Comprehensive means that we deal with all types of hearing implants, from bone conduction to ABI, including middle ear implants, as well as cochlear implants in all their variants. We try to create educational material such as this roundtable and other educational tools in written or video format, both live and online. And finally, we are coactive. We are a coactive group. We cooperate among us to create multi-center studies that give a much more weight to our research. Just a quick reminder of some important details for those of you connected online now. Please quit all other programs for best internet connection. If you remain with other programs, that may make a worse connection. So please quit all other programs. Mute your microphone and your telephone if you are not speaking. And please finally name yourselves so that we can have an idea of where are you coming from and what's your name and your country. At Hearing, we want these roundtables to be really interactive as possible. And to achieve this goal, you can ask the speakers directly or give your opinion on the topic being discussed by raising your hand, like in the application you have here, or just by using the chat in your Zoom connection. I will try to bring all the questions and comments to the experts and bring them all your input. You also will have captioning if you need it. It will be available. And finally, one of the advantages of this program of online roundtables is that they are fully recorded and remain accessible to everyone on our webpage. With this, the number of people that can watch every episode is much higher than just those connected online like you are now during the real development of the event. This roundtable is accredited as a CPD activity, and I will give you more information about accreditation details at the end of this roundtable. And this time, as you will see, we will have, rather than a purely online activity, we'll have a hybrid activity. As you will see in a few minutes, most of our panelists today are live and together in the studio. Only Grit Mertens and Miriam Calvino, as well as myself, will be connected online. The others are there live. And as a special Christmas gift from the Hearing Group to all of you, we have a very special topic for today's roundtable. We call this roundtable, What Language Do You Speak? And I will tell you more about this title in a while, and you will understand probably why we call this What Language Do You Speak? But before we start with the roundtable, and to demonstrate that we really want you to participate, I would like to ask you to switch on the camera of your phones and scan this QR code here on the screen, or go to internet and enter www.menti.com, and you put the code 378-37926. We will ask you a couple of questions during this roundtable, very easy ones, but we need you to turn on the camera of your cell phones or go to internet, www.menti.com and 378-37926. With this, you will be able to answer our first question. And the first question is, what is your field of expertise? We want, very especially for this occasion, we want to know what are your professional dedication. Are you surgeon? Are you researcher? Are you rehabilitation, imaging, general practitioner, student, anything, audiologist, whatever you want to mention, so that we can have an idea of how is the percentage of different members of these teams, these rehabilitation, these hearing restoration teams. We have audiologists, we have speech language, we have clinical engineer, researcher, ENT surgeons, and all members of those teams I was telling you about are going to be represented today. Okay, you remember the title of this roundtable? We have now enough answers from that question. Do you remember the title of this roundtable? Is What Language Do You Speak? And this time, instead of being the moderator, the one introducing the panelists, I will ask them to introduce themselves personally.
Witam Państwa serdecznie. Nazywam się Artur Lorenz. Mam przyjemność reprezentować Instytut Fizjologii i Patologii Słuchu z Cayetan, gdzie pracuję już prawie 30 lat i gdzie kieruję Zakładem Implantów i Percepcji Słuchowej.
Hallo und herzlich willkommen aus dem Hearing Studio. Mein Name ist Anja Kurz, ich bin die technische Leiterin und die Audiologin aus dem Universitätsklinikum Würzburg. Ich arbeite dort seit 8 Jahren und befasse mich mit vielseitigen Themen aus dem Bereich der Implantologie.
Boa tarde, senhoras e senhores. Meu nome é Deise Tavora. Eu nasci no Brasil, por isso português, mas eu fiz meu doutorado em audiologia na Austrália e hoje sou diretora do Centro de Reabilitação Auditiva em Perth, Western Australia. Bem-vindo à nossa mesa redonda.
Bonjour, je suis Hélène Andries. Je suis une chercheuse postdoctorale et audiologue à l'hôpital universitaire d'Anvers en Belgique.
Goedemiddag allemaal, ik ben Griet. Ik ben een collega van Ellen, dus ik werk ook in het Universitair Ziekenhuis in Antwerpen in België en nu al sinds 12 jaar. Welkom allemaal.
Hola, yo soy Miriam Calvino, soy licenciada en farmacia con doctorado en biomedicina y posteriormente me formé en audiología. Desde hace más de 10 años trabajo en el Hospital La Paz, en Madrid, participando activamente en los diferentes estudios que se llevan a cabo dentro de la red Hearing.
Okay, you're right. This is a mess. Most of us didn't get a single word of what they said. And the reason is that they were speaking their own personal native language. We were listening German, Polish, Flemish, French, Portuguese, and Spanish. A real Tower of Babel. According to the story, a united human race speaking a single language and migrating eastwards came to the land of Shinar. There, they all agreed to build a city and a tower with its top in the sky. And God, watching this tower, confounded their speech so that they can no longer understand each other and scatter them around the world. Now, for the second Mentimeter question, I have another easy question for you. After the Tower of Babel, where did your family end up? In other words, what language do you speak? Go back to Mentimeter and answer, please, what language do you speak? So we have Arabic, it's a majority of Arabic, Italian, English, Dutch, German, Portuguese, English and Arabic. Well, it's Dutch, Polish. We have also people, Hindi, Italian. So we have a lot of different languages, a lot of different persons from different parts of the world. Okay, Arabic is, again, the majority. German is following Arabic, English, Portuguese, Dutch, Netherlands. Okay, well, this is exactly the same that happens when we try to report the impact of diseases, disabilities, and health conditions. We do not have a common language. And this roundtable will try to provide information about a tool that can be used as a common language, especially in the world of cochlear implantation. This tool is called the ICF, which stands for International Classification of Functioning Disability and Health. The ICF is a project of the WHO that appeared around 2 decades ago after years of development and refinement. And the purpose of the ICF is to provide a standard language for describing disabilities and functions that can be associated with health conditions. I know this is not easy to understand. So let me give you an easy example. Imagine I have a hearing loss. I go to the doctor and end up with a diagnosis of mild bilateral sensorineural hearing loss. Period. Now, think about the real impact of that hearing loss on my daily life. How will it affect my social life, my professional life, my family life, my personal life? And also, imagine that you can objectively measure these parameters I just mentioned, both before and after a hearing rehabilitation procedure. And finally, dream up a step forward and consider that all this information is given in a standard way that can be used for comparison among people from all over the world, irrespective of their language or nationality. Okay, stop dreaming. We have it. We have that. We don't need to invent anything. That's there, and it is called the ICF. And the hearing group has been working on it over the last years, trying to create a specific ICF classification for patients with cochlear implants. And this is what today's roundtable is about, applying the ICF to the cochlear implant patients and try to have a common language that can manage all these people all these panelists, all these members of this roundtable in different languages may have a communication just by using this ICF, this common language. And for this purpose, we have the following experts in our roundtable today. Okay, online, we have Miriam Calvino. Like me, she's in Madrid. She had a degree in pharmacy and a PhD in biomedicine with special focus in audiology. This is what she said in her Spanish introduction. She's the responsible of the research projects from the hearing group at La Paz University Hospital in Madrid, with more than 35 projects on her CV. And online also, we have Grit Mertens. Actually, Grit was trying to reach the others in the studio, but her car decided that Germany was a better place to stay, and she's now in Germany trying to get fixed her car. Grit is professor of the Antwerp University, and she's coordinating the clinical cochlear implant research program at the ENT department of the Antwerp University Hospital in Belgium. She's the co-author of more than 40 papers and has presented her research outcomes at more than 50 international conferences. And now let's travel to the studio to meet the rest of the panelists. In the studio, we have Anja Kurz, starting from the left of your screen. There you have her. Anja is the technical lead at the Comprehensive Hearing Center of Würzburg. This center runs a large hearing implant program covering all the implantable hearing devices and conducts up-to-date research on multiple topics. Anja has over 15 years of work experience in the hearing field. We have by her side Arthur Lorenz. Arthur is professor and head of the Department of Auditory Implant and Perception of the World Hearing Center at the Institute of Physiology and Pathology of Hearing in Warsaw. He has received the first award from the Minister of Health and Social Welfare for outstanding achievements in healthcare. By Arthur, we have sitting in the studio, Ellen Andries. Ellen is a postdoc researcher and clinical audiologist, currently working at the Department of Otorhinolaryngology, Head and Neck Surgery at the Antwerp University Hospital, and her research is focused on the impact of cochlear implantation on health-related quality of life and the implementation of the ICF model in cochlear implant outcome evaluation. And by her side, last but not least, we have Daisy Tavora, who was speaking in Portuguese, but she could have been speaking in English, as she will do, and in Spanish and many other languages. And Daisy is the head of the audiology department at the Fiona Stanley Hospital and the adjunct associate professor at the Medical School of the University of Western Australia. Her research has been focused on treating single-sided deafness and associated tinnitus with cochlear implants, among other topics. Okay, let's see if we can make this ICF language, this common language in medicine, appealing to all of you. And to start, we will have a short presentation of each one of our speakers. And the first one will be Anja Kurz, that will deal with the value of the ICF. Anja.
Thank you, Javier. Well, you've seen now a couple of us here live in the studio and some remotely. But of course, we're a huge group and we have all different backgrounds. So you've seen now myself, you've seen Arthur, Daisy, Miriam, Alan, and Grit. But we also have engineers and speech therapists. For example, we have Yassin in our group, and we have Karin König, for example, our statistician, and Alona from the research department. So we all have different backgrounds. So we're not only audiologists, speech therapists, researchers, statisticians or engineers. We all have different backgrounds, but we do research together. So as you've seen at the beginning, we all speak different languages. We all have different backgrounds. So how do you imagine can we work together, given that we all speak different languages? So a good idea is the ICF model. The ICF model is a universal classification model. And the idea is to have a standardized description of functioning and disability using categories and qualifiers. And you're going to learn what this really means and how we've implemented it. It allows us, being spread all over the world, to compare our outcomes, our interventions across institutes, countries, sectors, healthcare disciplines, across all people and time periods. So, as you've seen, we all have a background and a huge interest in doing research and help hearing impaired people. So the focus is on hearing loss. And we are all aware that cochlear implantation is an evidence-based key intervention to restore hearing in individuals with severe to profound hearing loss. But it does not really help to just give an implant to a patient. There are many people around, there are many interventions, there is a lot happening before surgery and after surgery. So after surgery, of course, we have the audio processor fittings, we have the speech therapy sessions, we also have psychological counseling and so on, so on. So how can we now measure what we've done may impact also the outcome on these patients? So the aim was of our group to develop a CI outcome assessment protocol that uses the ICF and describe hearing loss. So when we look at the ICF structure, we have two main domains. We have the functioning and disability. This is how we are describing the hearing loss, but part of these are body functions and structures, activities and participation. So this is clear, we have a hearing loss, we need an intervention. But we also see the patient in the context. And it's a patient, a human being is not isolated. So we have environmental factors, we have personal factors. And by using the ICF, we are now able to describe all those little features that may make a big impact afterwards. So at that point, if there are no questions.
Yes, I have questions. Well, your last slide, I'm simply a surgeon, and there are some surgeons also in the audience. So for me, the idea of environmental factors is a very philosophical issue. Can you tell me, environmental means the weather conditions, or what does environmental mean in the ICF classification?
Well, in the ICF classification, the environmental factors mean like the cultural context, for example, or the communication mode. As we are dealing with hearing loss, there are different modes of communication. Is it sign language? Is it oral language? And so on. So these are all factors that do have an impact also on the outcome. And if we have, for example, an intervention, a hearing aid, a cochlear implant afterwards, the way how we're dealing with it, the way how we're using accessories, they also have an impact on that. So everything that comes around the intervention, these are environmental factors.
Okay, I just want to make a comment. The questions is directed to you because you are the one who did the first presentation, but I would like to know the opinion from all of you, from all the members of the panel. So if you want to say something, just let me know, and we can proceed with your answer, right? Okay, so when I was starting my medical career, we got something called the ICD, the International Classification of Diseases. And this was a very complex way of knowing how to classify the diseases. And is this in competition with the ICF? I was never very happy with the ICD, but is this the same thing? They pretend the same thing, or it's different things? Or what can you tell me, all of you, about the differences between the ICF and what we had till now, the International Classification of Diseases?
Well, I would like to volunteer to answer that question too. So no, the ICD and the ICF are not in competition. They are complementary because the ICD describes the disease. Yes, well, we have a disease, but then we have an intervention. And then this is about describing health conditions. So the ICF is really about health conditions. It provides a framework in describing, okay, we have an intervention, we're doing something, and what does the outcome really means? What is the impact? So it's not only this is the disease, go and live with it. No, it's the context within. So it's complementary.
Okay, thank you very much. I think we have a question from the audience. Professor Hagen, are you wanting to ask the panelists something related
Yes.
to our topic today?
Can you understand me?
Very well.
That's,
You
that's
speak in a very
nice.
good language.
Greetings from Sardinia. So my question is, it sounds a little theoretical, this classification, and looking to the topic hearing loss, people who need a CI is a minority. So maybe what's the real aim of this classification in hearing loss? Because that's so many people have the problem with hearing loss, but only a minority needs a CI. What's your opinion about this?
Okay, who wants to answer? Ellen, Arthur, go ahead.
ICF is a very general model, so it suits for everybody, not only for the hearing loss, but for all disease and disability. And talking about the ICF for cochlear implants is just like an example how we use this model to communicate with different professionalists, different sort of a stakeholders that everybody can understand, even if this topic is like it was said, applied for only a small part of people with hearing loss. But ICF allow us to actually use the language that is not specific for this group of patients or this group of specialists, but can be understandable for everybody.
Okay, now, sorry, Arthur, I was telling you that I think you should keep with the microphone and try to continue with the topics of this roundtable, which is the cochlear implant ICF process, because this was the question of Professor Hagen.
Okay, I start actually from a very short introduction that this ICF, using the ICF for CI process was initiated in 2016. I presented on the ICF and about the idea how to use this language for outcome measures after cochlear implantations, and there were a couple of actions, and also on next hearing meetings we discuss in detail, and actually this work was concentrated on three actions about the awareness of ICF, about how to exactly link ICF to the outcome measures which are commonly used in CI world. And next, we validate our work of this linking process. So basically, the linking process is the way how we want to connect the CI outcomes measures with the ICF category. That's why during the hearing meetings, the expert appraisal has been performed, and we selected the most common CI outcomes measures, and we connected them to the ICF categories. So first of all, to the body functions, and next to the activity and participation. So for example, the unaided pure tone audiogram or aided pure tone audiogram was connected to the sound detections from the ICF and so forth. So we use the clinical common methods, and we also for the body functions, but for the activity and participation, which is more the perspective of our patients, we use the outcomes of questionnaires. But this was a half of the process. The second part of the process was to find the linking to the so-called qualifiers. In the ICF, we have 5 qualifiers: no problem, mild problem, moderate, and severe and complete. And here on the slides, you can see one of an example how we did that in terms of different languages, speech tests we use in the clinics. And the problem we faced before was that these results of a speech test were very difficult to be comparable between centers, between studies, because each language has its own difficulties and characteristics. So the let's say the outcome test results like 90% in Spanish, it's not equivalent to 90% speech discrimination in Polish language. But if we found the good, proper method of linking that to qualifiers, and we did that using these techniques that we decided that, for example, 80% and that between 80% and 100% in Polish means no problem, but in Spanish language, 90% and 100 means no problem, and so forth. So this enables us to actually use the outcome measures as a qualifiers instead of a percentage, which can be comparable between languages, between a study results of a different study in a different center all over the world. And this idea, this actually method was next validated, but in terms of a validation, that would be a next presentation by our colleagues, Ellen.
Okay, Arthur, what is wrong with the traditional way of reporting CI outcomes? Why do we need to create such a, allow me to say, complex system that we are trying to create with the ICF classification?
The very short answer is that because of this complex system, we will be simple. But to explain that a little bit into the detail, I think nothing is wrong with the traditional way of reporting, but this is restricted to the small group of specialists. If I say that the free field threshold in a CI processor is 40 dB on average, it is difficult to interpret if it is okay or it is not a good results. But if I say that there is no problem in sound detection, everybody can understand it. So this is one main purpose. The second purpose is that as I try to present on an example of speech test, we end up with results, outcomes that can be comparable and used for the multi-center study. So there are two main advantages. One is that it is simplified, the language is simplified and easy to understand by non-professionals. And the second is that we can use this type of reporting for the multi-center evaluation.
Professor Hagen. Rudolf, unmute yourself. And
if you have a patient and you tell him now you have a problem with hearing, he asks you, please tell me what's the degree of my disease. So I have maybe 10%, 100% hearing loss. Is it similar in the ICF classification because you focus on CI, and these looking to the qualifiers seems quite similar in all different testings, but what can you tell the patient? Because the patient comes to you and wants to know, what about my hearing? Have I a hearing loss 10%? Have I 50%? So these classifications already exist. What is the advantage of ICF?
who wants to answer? None of
Okay,
you?
I
Wow.
I volunteer for continuation.
A short
answer,
answer,
Yeah,
please.
the quick answer is that patients are not only interested in hearing, they are interested in how they can functioning with this disability. So ICF gives the answer if the activity and participation could be normal, or maybe there would be some mild problem, a moderate or severe problem.
Okay, Miriam, can you give us an easy example of a tool that we need? How we are going to do this in practice, in real situation?
Okay. So in all this process that Tanya and Artu have spoken about, we realized that we need a tool, as you say. So we're looking, please, can you put my slide? Okay, thank you. So we were looking through the system biography, and the word rehabilitation questionnaire was selected because it provides a common language to define the health state of individuals. The word rehabilitation questionnaire was originally developed to measure ICF categories selected from the ICF core set for vocational rehabilitation and assess word-related functioning. It was modified and reduced for 59 to 70 items assigned to ICF categories relevant to cochlear implant users. It consists of two parts addressing demographic and relevant background information, that is the part 1 of the questionnaire, and word functioning, the part 2. Each item in the word represents an ICF category. Part 1 consists of 4 items, and part 2 includes 14 items. And you can see, as it is displayed in the table, the result of the revised word question will be assigned according to the same quantified qualifier as the original word. It ranges from no problem, with a word result from 0 to 2, to complete problem, from 9 to 10. So you can put my slide away, please. I try to be sure.
Thank you very much, Miriam. Thank you very much. I want to ask you a question, and we have 2 questions from the audience. My question is, we should have, like, I wouldn't say hundreds, but a lot of different questionnaires. Why did you choose the questionnaire for the work with Q?
Okay, thank you for your question, Javier. This questionnaire was selected because it consists of relevant questions for cochlear implant users that are not all included nor linked to the ICF and other existing instruments after a revision of the bibliography. It was chosen, as Artu have also mentioned, based on the consensus achieved among our expert group during our pre-study workshop.
Good. And the questions from the audience. The first one, I have been reading it, but I don't. The question says, what would be the process of incorporating a new language to this classification? Who wants to answer? I understand that how can we implement this in a different language? I understand that this is the idea of the question. Who wants to answer? Ellen.
So if you want to incorporate another language, then first you need a test that's comparable to the other tests that we used. for example, speech in quiet, we used either monosyllable or a bisyllable test. So you need that in your language. And then how we did it was our statistician calculated the qualifiers based on the division of existing data and norm data of the tests. So you would need norm data of the test you want to use and a lot of existing data to be able to do the calculations. And then you can add a new language to the test, to the category and qualifiers.
Okay. Thank you very much. I hope this is answering your question. And the other question says, can we know the factors influencing the outcomes from ICF or only measuring the outcomes? Know the factors influencing the outcomes or only measuring the outcomes? Great.
Yes, sorry, the question is not completely clear to me.
I think that the question means if the ICF is only good for measuring, or we can also identify the factors that influence the outcomes, the reasons for those outcomes. This is what the question says. So yes, Arthur.
Maybe I try to answer to that. First of all, we have some previous research on ICF and hearing loss. There are some lists of a core set of ICF for particular disability. So there are also lists of the most frequent factors, environmental factors that can actually influence the outcomes. So the beauty of ICF is that we have a tool to measure the outcomes and also to identify the environmental factors and try to see how these environmental factors influence our outcomes.
Okay, so keep asking questions, and let's move to the next presentation. Professor Hagen, I will go back to you in a minute, but we will have now Grit Mertens telling us about another tool concerning, in this case, the localization of the sound.
Yes, indeed. And maybe before I introduce our hearing classification system, I will try to explain how we include sound localization and how we define sound localization and why it is important to measure in our population. So people like us with a perfect normal hearing in both ears, we are able to localize where sound is coming from. For example, if a sound source is presented at your right side, then it will arrive louder and faster in your right ear, and it will arrive later and softer in your contralateral side, in your left ear. And so this information is used by the auditory brain to know where the sound is coming from. Now, if you don't have this normal hearing, this normal bilateral hearing, then this information is missing or disturbed. So you really need good input in both ears, or in other words, you need binaural input to be able to localize sound. And also this information is very important to be able to understand speech in background noise. So therefore, testing sound localization is a very nice tool also in our population with cochlear implants, because you can investigate the effect on the binaural benefits of our patients. Now, I hear you thinking, how can we measure this sound localization in our patients? For example, in Antwerp, we are using 7 loudspeakers in a semicircle. And then we are presenting different noises. In Antwerp, we are using narrowband noises. And then the patient have to indicate the speaker where the sound is coming from. And then you can calculate easily the localization error of that specific patient. Now, as I mentioned, in Antwerp, for example, we use 7 loudspeakers, a narrowband, and so on. And all these factors, like the number of speakers, like the duration, the type of stimulus that is used, can have a significant effect on the outcomes. For example, if you measure an error of 20 degrees in Antwerp with our setup, it's not the same as an error of the same 20 degrees as you would measure, for example, in Würzburg, because we're just not using the same setup. So then also in terms of localization, we do speak different languages, and therefore it would be great if we can also translate these outcomes of localization results into the ICF language. And so that's what we've did. So we introduced the hearing localization scale, which we can use to translate localization outcomes of your specific local setup into the different ICF categories. So going from no impairments up until complete impairments. So in order to be able to calculate these different categories with our hearing log scale, you will need the norm values of your setup. So from normal hearing listeners. And we would also need the chance level of your setup that can be easily calculated for each setup. And then the category, for example, no impairment in sound localization is defined as resulting 0 degrees up until 2 standard deviations above the mean error of the normal hearing group. And then the complete impairment in sound localization would be everything above the chance level. And then the other categories, so mild, moderate, and severe impairment, are equally divided between these two border categories. So this was briefly how we can translate our localization results into the ICF language.
Great, wonderful. We have a question from Professor Hagen. Rudolf, can you ask your question? Can we unmute? Yeah,
okay.
We have it now. Go ahead.
No, the problem for me is looking to a simple example. This is single-sided deafness. Single-sided deafness, maybe the patient says, I have a normal life with my single-sided deafness. And there are other patients who say, I have really a severe problem with the single-sided deafness because I have special situations where I cannot cope with. So how you have now, I recognize you have 5 different situations from normal to severe. How can you classify single-sided deafness in the ICF?
Great question. Go ahead, Grit.
Yeah, because indeed also on my slide, I give just an example on single-sided deafness. So what did we do in the different centers? We used this hearing classification system and we applied this retrospectively on data on single-sided deafness. So then we were able to pool all this data, and then we were able to say that without the cochlear implants, then they had on average complete impairment on sound localization, but then when they switch on the cochlear implants, they shifted towards only moderate impairment in the CI-aided condition. Of course, this is measured in a test booth. Some of the centers don't have the localization test set up in place in their centers. So that is why we also included subjective sound localization, because I think it's important to combine the objective results as well as the subjective results, because some patients, even if they perform very well in the booth, they still say that they are not quite able to localize where sounds are coming from. And there we can also report on whether they perceive it as a poor impairment or a complete impairment and so on.
Good. Can you give us a real example, Grit, some thing that we can see exactly how you apply this ICF localization scale?
Yeah, for example, this single-sided deaf data that we pulled with all the centers together, I think that's also presented on the slide as an exact example of how we applied the hearing classification for localization on our data.
Okay.
Yeah.
Okay. Let's move to one of our experts dealing with the application of the CI world into ICF classification. Ellen is going to speak on the first presentation about the validation of the cochlear implant ICF.
Yes, indeed. So how did we validate our ICF new tool? So we conducted a longitudinal multi-center study in all participating centers. So all people sitting here and on camera there have participated. So it was in Antwerp, Madrid, Würzburg, Warsaw, and Perth. We included adults receiving their first CI who were eligible for the reimbursement criteria of their country, and who also were fluent in the language of their local center. And we did measurements that were included in our ICF categories and protocol. So we did questionnaires, the work that Miriam talked about, also the AFAB, the APSQ, SSQ12, and HISQ-19. And we also did hearing tests, so pure tone audiometry, speech in quiet, speech in noise, and sound localization, as Greet talked about. And we did these measurements pre-operatively, and then 6 months after the activation of the cochlear implant to actually validate the ICF protocol in clinical practice.
Okay, Ellen, I mean, we know how the real situation of daily work we have in our hospitals. So you have like 1, 2, 3, 4, 5 different questionnaires, the hearing test, the conventional studies. So do you need several days to diagnose the patient, or you can do it in a shorter period of time?
Luckily, we don't need several days. It would be a bit long for clinical practice. No, what we actually did, the questionnaires we included can be filled in by the patient at home, for example, on paper or on a computer if the hospital has a system for online questionnaire data. So actually, the patient can do the questionnaires at home. So the clinic time is only for the hearing tests, and normally those take about 30 minutes. So normally the clinic time for administering the protocol is about 30 minutes.
So you mean you have to use 30 more minutes for every patient, but no more than that?
It's actually in clinical routine, the hearing tests we do. So you already need those tests in clinical practice. So you don't actually take a longer time than normal than you usually do when you see the patient, because for the fitting you already do these hearing tests normally. Okay. So you don't lose time by using the protocol. You just have to send the questionnaires to the patient, but that's all actually. But,
and the questionnaires, I mean, those questionnaires can be answered by any patient. I mean, cultural level, social level, of course, not with problems, but normal people can answer all these questionnaires easily at home.
Yes, they're commonly used in the field of cochlear implantation, and they exist in several languages, which is also good for multi-center studies. So that's why we chose those questionnaires.
Okay, Rudolf, go ahead. Unmute your microphone.
Okay.
Yeah.
So the general question is, how can you implement this ICF system into clinical practice?
Well, that's a good question. Who wants to answer? I mean, we want to do it tomorrow. What do I have to do?
What do you have to do? You have to get the questionnaires and do the hearing tests. And then, well, if it's already in the product.
How bring it to the general health system of all these countries? You know, in all these countries, there are different health systems, and it would make sense if we have really a common language. But in Germany, it's completely different to maybe South Africa. And how are these results of ICF classification also recognized by the insurance companies, for example? If you say I have the ICF classification moderate, what is the consequence of this classification?
Oh, I think your question doesn't have an answer. It depends on every place. Arthur.
I think that for the insurance company would be more convincing if I say that for the functioning like activity and participation before intervention, before CI, patient had a profound problem, a severe problem or complete problem, and after was just mild problem or no problem at all. So we are using ICF like on the top what we are doing routinely. It's just a language. So we are doing our evaluation, and ICF can help us to translate the outcomes like dB or percentage of speech correct response or RMS error in degree to the categories catastrophic problem, severe problem, mild problem, or no problem at all. So this is the concept of ICF.
Ellen, why? I think you mentioned you have 6 months follow-up.
Yes, indeed.
Isn't this a bit short period of follow-up?
Well, 6 months is the most critical period in the rehabilitation of a CI patient, and we would expect most improvement to be at 6 months post-operatively. But I do acknowledge that in a longer follow-up, we could see some more improvement in, for example, activities and participation. But the most improvement we would see at 6 months post-operatively already in most patients. So that's why we chose the 6 months post-operative point.
Okay, can you tell us about the progress over time using the ICF qualifiers?
Yes, it's in the next presentation. I can tell you about how we visualize it and how it progresses over time with an example. So here you see the slide. It's on the subdomain activities and participation, and I'm showing you the results for D910 community life, so the ICF code and ICF category. And I've visualized it in a Sankey diagram, but how to read this Sankey diagram? So you can see on top the rating, so the qualifier. So it goes from 0, no limitation or restriction in dark green, to 4, complete limitation or restriction in dark red. And then you see on the figure itself, it's about D910 community life. It's measured with the work questionnaire, question 13. And then you see on the left the pre-operative data. So it's the N value, so the amount, the number of people on having this kind of limitation, with the percentage of people between brackets. And then on the right, you have the 6 months post-operative data, again with the N value, so the number of people, and then the percentage of people between brackets. And then you can see that pre-operatively, there were more patients suffering from a severe to complete limitation for community life, so participating in community life, compared to 6 months post-operatively. So you can see that there is an improvement in this category by looking at the Sankey diagram.
Okay, can you keep this slide here while we go for the discussion? Because I mean, this is beautiful. Looks like modern art, but I cannot understand why a patient with cochlear implant being up here in the green part before the operation can end up after a cochlear implant on the lower part of the graph. Ellen, can you tell us the reason for that?
Yes, there are actually multiple reasons for that. Firstly, we didn't have very tight inclusion criteria. So if you want to have a holistic measure, you also have to have holistic inclusion criteria. So we don't only have good performers with the CI, we also have some poor performers in there. So that partly explains it. Second explanation could be that it's 6 months post-operatively. They're still in their rehabilitation program. So they could still be adjusting to the cochlear implant at this time. So that's the second reason for this.
Okay, so why did you choose one question of this? Is just an example. I mean, you use all the questions. You have a Sankey diagram like this one for all questions, so every questionnaire?
No. For the work questionnaire, the questions were already linked to the ICF. So each question from the work is linked to one category. But for the other questionnaires, that's not the case. Then you have, for example, in the AFAB questionnaire, you have the total score that's linked to a category. So normally it's the total score or the mean score that's linked, but in the work, because it's already ICF based and it's already, every question is already linked to a certain category. In the work, we can use separate questions for each category, but it's not the case in the other questionnaires.
Okay, good. You can remove the slide. And concerning the questionnaires, and this is a question for you and for Miriam also, who was dealing also with questionnaires in GRID, and okay, for all of you. But anyway, concerning the questionnaires, there is a concept in the ICF classification, which is the major life areas. And we may end up with a common language, but I don't understand it. What's major life areas? What do we consider major life areas from a practical standpoint? Miriam.
Major life area refer about carry on the tasks and action required to engage. It refers to education, work, and employment. And these items are reflected in the work questionnaire. Because, for example, participants are asking about the background information and about their work status and education level. So one question is that participants have to answer about the highest educational level they completed. That's it, if they have no study, primary education, secondary education, or even the highest level that is considered as a postgraduate degree. So this specific question is linked to one question of the work questionnaire.
Okay, so and the concept of body functions. The concept of body function is another question that comes very often in when we measure when we try to assess the outcomes with the ICF. And can someone give me a real example of what the patient has to answer when you ask him about the body functions? Miriam.
Okay, I answer the question because again, the work question can answer this question. So a specific question is that overall in the past week, to what extent did you have problem of tinnitus, for example? So the patient have to rate from 0 to 10 to which is the score that is considered that is better similar to their status. I said tinnitus, falling, and so on.
Ellen. You want to add something?
So I was actually going to say quite almost the same as Miriam did. It's indeed a very good example of a body functions and structures question from the work. But body functions and structures is also not only measured with questionnaires. We have also the sound detection, for example, which is measured with pure tone audiometry. We have speech discrimination that's measured with speech in quiet and speech in noise. So you don't only use questions and questionnaires to measure everything. We also have more objective tests. Like pure tone audiometry, speech in noise tests for every country, also speech in quiet tests for every country. These are the examples.
But with that, we have that already. I mean, this is something that we already have. We agree that this is not enough. So the plus that we are adding is just the questionnaires.
It's not just questionnaires, it's also this linking concept. So therefore we have like a holistic and multi-dimensional way to evaluate our patients. We using the ICF and our qualifiers, we can actually assess the body functions, like one big domain, but also the other big domain, they are functioning, so activity and participation.
Okay, let's move to the use of the ICF in clinical practice. I think, Daisy, you can tell us something about this.
Yes, I can, Javier. And I think that probably now, as you said at the beginning, it is quite confusing. And I agree with you. The first time that we talk about the ICF classification is quite confusing. And I'm really hoping that with this slide, it can shed some light on what we are trying to do. We are not replacing what we are doing. We are creating a codification, a classification, whatever you want to call, that actually can make it easier to report. So what I put on this slide here, for example, the top table is what we use, all right? EU, and probably everybody in the audience will understand. I'm talking about 3 field thresholds, and then what we do is we present an audiogram, yeah? If we are talking about, in English, we use the CNC, speech perception score, in quiet. Then we report that the patient has 10% pre-op, and then he has 50% post-op, and so on. So the speech in noise gets even more complicated because we say, well, the patient is getting 10.5 dB SNR. You know, Arthur know, Anya know, you know, who else know? Does the GP know? Does the patient understand what we are saying? The localization, I think that is even harder, as Arthur said at the beginning, 30 degrees RMS. This means absolutely nothing for the general population. So we are doing this test. We are not substituting these tests. What we are doing is creating a language that is common, that anybody can understand. So in terms, instead of using 3 field threshold, the audiogram, that only us can read it, we can say, well, the patient had a complete impairment in terms of detecting soft sounds. He had a complete issue, a problem or impairment before the intervention. And these went down to 25 dB, which means that is a mild impairment. I think that makes it very clear and very obvious, even for the insurance companies, as Professor Hagen was asking before. So instead of talking about CNC, speech perception score, that means a lot to us, but it doesn't mean anything else to somebody else, we can say, what is the understanding of speech in quiet? It went from complete impairment to a mild impairment or a moderate impairment. Right? And the same thing for localization. Even if you are not using even if you don't have the setup for localization, and you are using a subjective report from the patient how he can localize, you are still able to report, well, this patient rates his localization ability as a complete impairment, and now after intervention he improved it to a severe impairment or moderate impairment. So I hope that this table make it clear to you, Javier, and to the audience, what we are trying to do. So we are actually not replacing, we're reporting it differently. And I just want to add, like, for example, when Professor Hagen asked the question about insurance, if we refer to Australia, for example, we had a new national disability scheme where we provide a report what the patient is achieving autologically speaking. They check this report to a person who represents them in terms of how much financial help they are going to get. This person has no idea what we are saying in our report. So we actually have implemented this, and this is not new, to be honest with you. Probably we are one of the last ones to implement. A lot of professional allied health is doing it. I have seen report from physiotherapists, from occupational therapists, from podiatrists, actually reporting what is the level of impairment that disability is bringing to the patient. So I think that we are just updating ourselves there, to be honest.
Very good. I mean, Daisy, you did a great job. You could make a surgeon understand the ICF application in daily clinic. So I want one more thing. Tell me, what do I have to do tomorrow if I'm not involved, if I was not involved in this project? Tell me, what do I have to do tomorrow in my everyday clinic to apply the ICF language? What do I have to do practically?
Practically, I think that Ellen actually had covered this before, wasn't it? In terms of, well, if you are using one of the languages that we already have, I think that's very easy to implement because we have already worked on the qualifiers for different languages. I think that is only if it is not one of the languages that we have used so far, you are going to need to get all the norms for the test that you would do in your language and create the classification and using the qualifiers. But in your case, Javier, because you have Miriam, you are ready to go.
Thank you very much. I have a question. Well, I think it's more a comment. Well, it's more common than a question from the audience saying, the ICF may help the healthcare systems in different countries to better understand what hearing loss means and which societal impact hearing loss has. May this understanding ultimately contribute to increase reimbursement efforts for hearing solutions? I can answer you, no, in my case. In Spain, we will not get more reimbursement no matter what we do. But from other countries, what will be your opinion? Are we going to increase reimbursement efforts for hearing solutions if we apply ICF? Can you tell me in your own personal idea, Reed, for instance?
I think it can be very helpful for the insurances and for the reimbursement, yes, because of the benefits that Daisy already reported, because we then speak the same language, because we have to convince also the other professions that don't speak the language of, like he's going from 20 dB HL up until 10 dB HL, or with an SNR of this and localization error in degrees from this to this. We now have a common language to motivate how the patient is doing after intervention. And also, I think it's helpful that we will be able to pool more data, because in advance it was not possible because we were dealing with different languages, different setups, and now we can pool more data, so there will be more evidence available to convince the reimbursements and the insurances.
Anya, you think that will make an impact in Germany?
Well, I cannot really speak for Germany as a whole. I would just say, coming back to the question, how easy is it to implement tomorrow, if we start tomorrow? I can say that our speech therapists, they are already reporting, they are writing their reports using the ICF wording. So for us, we all have the data. So what would need to be changed starting tomorrow is how we report the outcomes. So we need to change, we need to tell everybody. So these are the words, these are the classification there where you put the results in, and you just describe the outcome in a way that everybody can understand it. Because after we see it in at health insurances, that people that get, for example, the results of speech and noise testing, the ALSA, and they get a -5 dB, well, they have no clue that it's really a good result. And then insurances are not likely to pay for example, an upgrade sound processor, so on. So by changing the language, how we report it, I believe would make an impact. But this would also mean that we all have to stick to that language.
Professor Hagen, Rudolf, can you tell us something?
Okay, there is a common language all over the world. This is called Esperanto.
Esperanto.
And nobody understands it. So is ICF like Esperanto? That's the first question. And the second is, of course, looking to the last contribution. There was, in my opinion, a very big variance in improvement from complete to mild, from complete to severe. So this is a very big variance. Can you comment on this?
Daisy, you want to comment? Or Ellen, go ahead.
Yeah, I think this is something we commonly see in literature and also in our patients that there is a lot of variance in the patients, and especially in the activities and participation categories and the environmental factors. This is not only caused by the cochlear implant itself, it can also be influenced by other factors that are not related to the cochlear implant. For example, we also have a question on emotional functions, if you feel sad or depressed, but this can also change because something bad happened in your life, but it's not related to cochlear implantation. So you have influences from other things too in there.
Okay, we are short of time now, but I would like to have a last comment. We know what the ICF more or less is, and my question to Grit is, what's next?
Yes, you're right. The ICF framework for adult CI recipients is ready to use. It's published, so more information can be found in the publications. And I hope that clinicians will use this ICF CI framework to report on their clinical outcomes in their CI recipients. And now that this adult version has been completed, the next step is obvious, I think, developing a similar framework, but then for the pediatric CI recipients. So our goal is the same as for adult CI recipients, to translate our minimal outcome measurements that we have for the pediatric CI recipients and translate it into the ICF language so that we can all understand and pull the pediatric CI data collected at the different centers worldwide. Now, it took us more than 5 years to develop this ICF language for the adult population. So you can imagine that the process requires even more preparation for children, because this group is a more heterogeneous group with many, many more factors to take into account. For example, we have to consider the chronological age of the child, the hearing age of the child, also the communication mode, sign language versus spoken language, type of education, and so on. So what are the steps needed to proceed with this pediatric ICF framework? Luckily, we have the experience from developing the ICF framework in adults. So in a first step, we selected the most relevant outcomes in our pediatric CI recipients, and then we will link them to the categories, and we therefore start with the minimal outcome measurement test protocol that we've got already in place. And at this moment, we are finalizing the protocol and the framework for the pediatrics.
And for the pediatric group, I mean, the questionnaires, I understand that the audiological measurements are different to adults, and questionnaires, how do you get answers for questionnaires from the pediatric group?
Yeah, luckily we don't have to start from zero. Many research has been performed on how to question the process in children, like parents that have to fill out the questionnaires, and those are already validated questionnaires in place that we also translated into the ICF language. And for the items that are not covered in the validated questionnaires that are available worldwide, there we also included the work questionnaire with different questions.
Okay, do you have the other panelists? Do you have any experience with the ICF in the pediatric field, Arthur?
We are just working on that, and of course it's not easy, but we have as Henriette mentioned, we learn how to get this process done in adults. So we hope to produce the same guidelines as for pediatric population. But just at the end, I really would like to share our hope that this ICF would not be as Esperanto. That's why that was a really huge effort under hearing to produce sort of a cookbook, sort of a guidelines is to help clinicians to use this language, and we also would like to encourage everybody who is interested to contact hearing group, and we would be very happy to help.
Okay, I want just a last word from each one of you, a short answer to the question. Anya, you wanted to say something?
Yeah.
No. I didn't see you. Do you want to say something? Okay, my last question to all of you, starting from you, Anya. What are, just try to convince, you have a number of people now online, but this will be seen, as I mentioned at the beginning, for a lot of people during the next weeks and months. So try to convince them and tell them what are the advantages of ICF for reporting CI cochlear implant outcomes, very shortly.
The big advantage of using the ICF and reporting the outcomes for CI is that everybody is understanding what's going on. We are not reporting only numbers. We are telling the patient what he already knows, but we put it in a language that he or she can understand. And the same for all the environment around, and also for practitioners, health insurances, and so on.
Arthur, very short, advantages.
Advantages, not only the impairment, we are using the holistic model of disability, so we are including very holistic evaluation from also the perspective of patients, so the activity and participation domain.
Ellen,
Yeah.
tell them the advantages of this system.
So I totally agree with the advantages of Anya and Arthur mentioned, but I have one extra advantage, that it's a standardized way of measuring CI outcomes, and that now the very different methods are used, and there's lack of consensus in studies and in clinical routine about what to use to measure these CI outcomes. And this gives a solution to that. You exactly know what you have to measure and what's coming out of it. It's clearly reported, and it's not only about hearing.
Daisy.
Yeah, sure. I would like to add something. I think that using this language, we are going to remove, we have the potential to remove some misunderstanding and communication, all right? Because in terms of counseling, for example, if we use, for example, if the patient is moving from a complete impairment to a severe impairment, in the past we used to say, well, that was a significant improvement. What actually does significant improvement means? But we can use that, well, you moved from complete impairment to severe impairment. It is an improvement, but you still have a disability. And this can be used for insurance purpose, for example. I think that we remove that language that is not understandable and create miscommunication, misunderstanding, and can be used in counseling, for counseling.
Thank you. Agreed. Last comment.
Yeah, I think an important part of our job is to report on how our patients are doing before and after the intervention. So we have to write reports whether we like it or not. And I think this is a language that can help. And also the insurance asked to use this framework to report on the benefits of the patients. And now we are also thinking to make like an application or something that can help us writing the report. So I think in the future, this would be a great tool for reporting on the benefit of our patients.
And finally, Miriam, convince your Spanish colleagues.
Yes, the main advantage for me is that we can compare my result, mainly the speech outcome, to the rest of my colleagues that live around the world. So this is what they say at the beginning, that what language do you speak? So it just is a summary.
Excellent. Well, we have been, believe it or not, almost 90 minutes dealing with Esperanto in the world of cochlear implants, a new language allowing us to share the outcomes of our cochlear implant patients all over the world. I understand that for many of you, the ICF classification may sound a bit difficult to understand and to apply in every day in your clinical practice. In fact, I had the same feelings less than a month ago, before the in-depth study of the details of the ICF classification for the preparation of this roundtable. So I didn't understand many things, but I think that if you are interested in the problem and you take a careful look at the literature dealing with the ICF classification in general and the modification made by the hearing group for the specific case of cochlear implant patients in particular, you may find this a very useful tool. At the hearing group, we have been working on this common language for some years now, and we will keep pushing the project, trying to improve the communication between different groups of people, different centers, different countries, and different time periods to improve the ability of comparison and communication. We're almost out of time of this 90 minutes roundtable, and I just want to thank you all for your attention and participation. And before closing, I would like to mention some practical issues. At Hearing, we would love you to visit our webpage at www.hearing.com, where you can find tools like the Hearing Preservation Calculator, a very useful tool for clinical practice, the EAS fitting tool, or the counseling platform. Those are very useful tools that you can find in our webpage. And one of our basic pillars at the Hearing is the Hearing Boost, which is our educational platform. Basically, this is a learning management system where you can find a lot of different certified courses by hearing experts on genetic, natural hearing, bone conduction, all issues related to hearing loss. It's also in our webpage, and it's easy to find. And as I said at the beginning, this roundtable has CPD accreditation. By email, you can request your CPD accreditation, sending an email to boost@hearing.com. And it may take some time, but in about 6 weeks, you will receive 1.5 points for the hour-and-a-half duration of this roundtable. This has been our last roundtable in 2023. This is the program for next year. Let me remind you that we're preparing a very appealing program for the coming year that will be posted as soon as possible. We only have the exact date of the next one, which will be April 11, 2024. And as a group, we are a very active group of people. And these are some of the conferences that we will, as a hearing group, will be attending and having seminars or symposia. We will go in September to Argentina, to the 8th World Congress of Cochlear Implants in Emerging Nations. We will go in October to Abu Dhabi for the Arab Cochlear Implant Conference. And also in October, we will also go to Rome for the Pulitzer Society meeting. Send us your doubts, your questions, your comments, anything you want to our webpage. Again, www.hearing.com. And we will be more than happy and pleased to answer and contact you and tell you our opinion on your doubts, or try to answer your questions. This is all for today. Until the next roundtable, have a wonderful Christmas and a very happy New Year. Thank you very much for your attention, and goodbye.